Welcome to the PROstep MIS Lapidus live launch event. Your host for the evening from the Core Institute in Phoenix, Arizona, Dr. Ryan Scott.
Good evening, everyone, and thank you for joining us tonight. My name is Ryan Scott from Phoenix, Arizona. We've got a great night planned for you guys. We've got some very special guests, not only live, but also via remote webinars. But tonight, really, the main purpose is to really get this launch off the ground. This is the PROstep MIS Lapidus. Great technology is really going to kind of evolutionize the way we look at things. Kind of to dive into the night, a little bit about my PROstep kind of walkthrough. Was I able to jump onto some of this technology in 2017? A lot of that was really kind of time changing and an adaptation for me, just kind of move my procedural basis forward with innovation. A lot of that came from that chamfered head screw originally in 2017 with David Redfern, and we kind of walked through the evolution with bunionette correction and then the solo guide, which really helped dial our bunion corrections in from a chevron standpoint with reproducibility. Along the lines came the arthrodesis burrs, which bring us to where we are today with the PROstep MIS Lapidus, and really kind of diving into a little bit more of the MIS aspect into the hindfoot, midfoot, and ankle. Upcoming, there's some really great commitment from Stryker kind of moving forward. We're looking at some more of that Solo 2.0 guide, so definitely keep your eyes out and looking forward to a lot of that stuff. So kind of diving right on in, we've got a great group tonight. We got Dr. Rebecca Serrato and Alistair Younger along with us as well too. So we'll kind of let them introduce themselves, kind of get into what caused them to kind of make that jump and where we're at today with the rest of the MIS standpoint. So.
Thank you, Ryan. Hello, Alistair. My name is Becky Serrato. I'm an orthopedic foot and ankle surgeon at Mercy Medical Center in Baltimore, Maryland. I have been performing minimally invasive surgery and using the PROstep line since it was first released here in the US. It has absolutely changed my practice, particularly my forefoot practice, for the better. And just like Ryan had sort of outlined, I started using it in all other aspects of my practice, whether it's joint preparation, hindfoot calc osteotomies, and even some really challenging procedures such as Charcot-arthropathy. But it definitely, if I think about how it's really changed my practice, when I think about forefoot, particularly bunion correction surgery, I think this is, as you'll hear again and again and again tonight, it's a game changer. And I think with Stryker's launch of PROstep MIS Lapidus, it absolutely is just one more tool in that MIS toolbox that you guys have.
Awesome.
Dr. Alistair Younger.
So, yeah, I'm Alistair Younger. I'm from Vancouver in Canada, and I've been doing MIS with whatever tools I've been able to get my hands on since starting practice in 1998. So my first delve into MIS was through arthroscopic surgery. So I started off doing arthroscopic ankle fusions, then arthroscopic triple, arthroscopic fracture fixation. And so when I first heard about the percutaneous systems, the MIS osteotomies using Shannon burrs, and until they got licensed in North America, it was a natural progression to expand my practice into that. And they're both complementary, actually, and we'll find that out as we discuss the PROstep Lapidus. So I've expanded my practice now. I found that the claw toe correction has been really fantastic. It really changed my practice, as well as expanding percutaneous surgery to reduce wound complications using the burrs for osteotomies. So I've now, as soon as we got the equipment in North America, I started doing percutaneous Lapidus. I've got about 300 done now. And now that sort of evolved into the PROstep Lapidus, which is again another natural evolution and really a way of making this a reproducible operation for everyone to do. So I'm really excited to be involved in all of this and this development. It's a huge step forward. So moving on, I'm going to talk about some of the obstacles that you might face in performing an MIS Lapidus. So obviously the first one is the hardest one, and it's a matter of being able to do it and know that you can do it. And so there's various steps involved. What you need to do is get 3 planes of reduction, before I went to the MIS Lapidus, I was doing an open Lapidus, and I got well over 1,000 done over the years. And my challenge to myself was to make sure that I got the same reduction with the MIS and the PROstep Lapidus than I did with the open. So we need to make sure that we're getting appropriate reduction and we're getting it maintained until we've got the final fixation in place. Now, we all get told to remove all the cartilage in a fusion. It's something that's drilled into us when we do our training, that cartilage must be removed if you're going to get a reliable fusion, and all the cartilage has to come out. And there's even debate whether or not you should penetrate the subchondral bone. So when you're preparing that fusion, you need to be able to get the access to get the cartilage out. And I'd encourage you all to make sure that you get cartilage out, because it acts both as a physical barrier. So if you leave cartilage in place, it'll prevent you from getting the bone apposed to bone. But it's also a biological barrier, because cartilage produces growth factors that prevent neovascularization that's so important for bone healing. So you want to be able to get proper cartilage debridement using the various tools that we are putting in your hands. And then you need a reproducible construct. Now, we're changing the way a little bit that we think about fixation. Everyone thinks of orthopedic fixation for fusions as either compression screws or as a plate. And when you use a plate, what you're really relying on is cortical bone and screws, and the strength of that construct is dependent on the strength of the plate. When you use compression screws, you have to squeeze the joint together to get stability, and what we're using is the subchondral bone to get good, strong fixation with full thread screws at a non-variable pitch going across the joint. So anytime that you're doing an orthopedic or a fusion procedure, you want to just check with yourself and see where the strength is, and the strength is in that subchondral bone, and the bone strength falls away quite rapidly as you move away from the joint line. So that's what we're using. So the subchondral bone preservation is a really important part of the design and the aspect of this surgery, and why we're using full thread screws with non-variable pitch. So we want this to be minimally invasive. So minimally invasive not only refers to the incisions, it also refers to the fact that the fixation has to be within the bone and not outside the bone, because if the fixation is outside the bone, the patient might feel it and it may require a second operation to move it. So we want to make sure that we keep the whole procedure MIS. There's lots of advantages of MIS that's been demonstrated in many areas of surgery, in orthopedics, obviously in the shoulder and the knee, and now we're seeing it in the foot and the ankle. I was driven to go MIS early in my practice because of high risk factors of wound healing, and it's the most devastating complication you can get in your practice. So if we go MIS, we avoid that. So PROstep MIS Lapidus has shown low recurrence rate compared with open Lapidus procedures. So we're showing excellent correction and maintenance of that correction. And that comes with the massive reduction in scar size. So less scar means less bleeding, less pain, early immobilization, less stiffness, and in particular, fewer wound complications. So we're seeing a decrease in recurrence compared with open Lapidus procedures. The PROstep Lapidus, MIS Lapidus, also addresses potential loss of correction, because obviously if you get delayed bone healing, then you're going to get potential recurrence. And the minimally invasive bunion surgery techniques result in less opioid usage, which is a really important duty for us as musculoskeletal surgeons. In particular, one of the observations we've noted is that the MIS joint preparation decreases non-union rates significantly. So the combination of keeping the soft tissue envelope, of maintaining the blood supply to the bone, of getting all of the cartilage out and getting this really secure fixation construct means that we can achieve really high fusion rates. In my own experience of the 300 cases to date, I've had one non-union I've been able to identify, and I've been telling my patients to mobilize basically heel weight bearing for the first 48 hours and then get back to weight bearing after that. And even with this, the construct is strong enough to get us these really high fusion rates. So I think this is the principles of subchondral fixation, maintain the subchondral bone, cartilage removal, and strong fixation allows us to achieve these high fusion rates. So what are we getting with an MIS Lapidus procedure? Well, it's reproducible. We can get correction in 3 planes of rotation. We get rotated, we can close the IM angle, and can plant a flexor first ray. So you need to achieve those goals in your surgical procedure. So that's the triplane or 3-plane correction. You need to make sure that we get maintenance of the joint surface, so that gives us a fixation, but it also prevents shortening of the first ray. We get fixation stability through the full thread non-variable pitch screws that we're placing, and as well as that we've got 2 screws, so that will give you better rotational control. And we've got the 3rd screw as well, the 1-2 screw. So we've got 3 screws maintaining the rigidity of the construct. We've got now multiple bunion solutions in the portfolio, so we can do the lower IM angles with the distal chevron Aitken. We can do the higher deformities or the unstable first ray with the percutaneous Lapidus. And we can also do this in combination and correct metatarsus adductors, that we can discuss a little later. And finally, we've got all of the education to support you. So with that, I'm going to hand off to Dr. Serrato, who's going to explain more about the procedure.
So the next couple of slides that I'm going to highlight are really the key design features that we're going to be going over in the subsequent videos during this next hour. So if we're talking about some of the key features, first is this triplanar reduction. And so as Alistair had mentioned, we're going to take the IM angle, we're reducing it, but we're also, this clamp gives you the ability to derotate the first metatarsal and also plantar flex or dorsiflex the first metatarsal and control them in all 3 planes. One of the other advantages, it features this ergonomic distal design. So once you've got your ideal position and you have it locked in clamp, now the clamp is in a position that's going to be out of your way when you're moving on to the next step of the procedure. This is where we talk about the actual joint preparation. And so the first tarsometatarsal joint distractor and compressor controls access to the joint for both preparation as well as, once you're finished with that powerful compression that you're looking for. The use of the arthrodesis burrs that Stryker's already launched is ideal for the MIS joint preparation because it's designed to preferentially remove cartilage only, therefore maintaining the bone length that we're speaking about as being so important when we're doing a Lapidus procedure. And then finally, we're talking about fixation stability. Again, 3-screw construct that's positioned and designed to create a tension band effect for maximum biomechanical stability, and therefore allowing us to feel a lot more comfortable, allowing our patients to weight bear almost immediately.
So hopefully now that we've had a chance to open up and discuss a lot of the fundamentals of this, we're going to kind of move into a cadaveric model and really kind of hear about that. But what we would encourage you to do is, you guys hear us talking and kind of see us walk through a lot of the cadaveric stuff, is please get questions in. The last part of the session is going to be Q&A, so please definitely send us in some questions so we have some things to discuss. So now we'll move into more of the cadaveric-based stuff and really more of a testimonial by Dr. Steinlauf first, and then we'll kind of move into the cadaveric aspect.
I'm Dr. Stephen Steinlauf. I'm the Chief of Foot and Ankle Surgery at the University of Miami in Miami, Florida, and have been doing MIS for about 5 years now, and we're real excited about new concept in minimally invasive surgery, and that's the minimally invasive Lapidus. So I think when we look at what we designed, MIS Lapidus is not simply a gimmick. It is a very different technique. It has nothing to do with the Lapidus procedures that most of us were taught. I was taught to use a saw and take away the subchondral bone, take a wedge out, compress, and put 2 lag screws, maybe 3 screws. The difference here is we're trying not to lose length, and we're trying to maintain stability by maintaining all of our subchondral bone. So we've incorporated our technology of minimally invasive cartilage removal with dedicated cartilage removal burrs. And what we're able to do is we're able to minimally open up our tarsometatarsal joint with a 1 centimeter incision, distract it, remove the cartilage, get good reduction with our reduction clamps, our compressor distractor.
So kind of moving into where we're at with everything, and Dr. Serrato and I will kind of narrate as Dr. Steinlauf is going through things, but the biggest thing here is always marking out your incisions and marking out where you kind of want to be before you kind of get started, especially if you're kind of newer to this situation. In this scenario, he's going to mark out both a lateral release as well as placement of the guide pin. What are your takes on one incision versus two incisions? What was your preference?
I feel very comfortable with two, and most often I'll do two. I mean, I think if the IMA is not that wide, potentially that one incision you can accomplish both. But typically in my scenario with Lapiduses, I find that I get the ideal release with the incision that I place for my lateral soft tissue release, and then separate to that, and again, these are all little percutaneous incisions. I'm very comfortable having them fairly close together. I make that separate incision so that I can place the clamp around the second metatarsal.
So I'm slightly different. If I can get through one incision, I do like to keep it through one incision. I think it's dealer's choice. Whatever your comfort level is, I think is absolutely critical and key. Moving on to the actual jig itself. It's a 1/6 wire being placed through the retaining slots to make sure that that rotational guide pin stays totally put. What you'll do is you make sure that you want to slide it through both the top and the bottom. This is a universal jig, and that's why you'll see one up top, one through the center, one through the bottom, so that way it's a left or a right universal compatibility. What you'll do is you go ahead and hook in and hook around, and go ahead and watch for your C-arm to go ahead and place. Any pearls you have during this step, or is it kind of just run and gun?
Usually, like he used the hemostat, I think that's a great idea. I'll put that in and sort of run down that lateral cortex of the second and go distal. Not very different than when you're doing like a DMMO, and you can feel the end point of the capsule. And that sort of tells me I'm in the right spot.
Great. So what you like to do is you like to check under floor to make sure that you've got appropriate visualization of both your superior and inferior holes. What I like to do is I like to place my pins through the jig itself on hand just to make sure nothing cold welds. Here you can see Dr. Steinlaw will put it in under power. I think it's probably surgeon preference. Would you agree?
Yeah, same with you. I like to, because this comes in at a very specific angle, so I just drop it in with my hand, and then either myself or my assistant will then place it across. As Dr. Younger will highlight with this, is you want to try to make sure this is as distal as possible into the metaphyseal portion of the second metatarsal, because you can minimize any sort of injury or fracture to the neck of the second metatarsal if you go a little more distal.
Anything to add?
Yeah, you want to also make sure that you rotate it so that the jig is going to be flat to the ground once you've corrected the pronation. So you want to tilt it a little bit into a supinated position on that jig. So if you've got, say, 20 degrees of pronation to correct, you want about 10 degrees on the second ray and about 10 degrees on the first ray. So as you close the clamp remains perpendicular to the floor, so that you can then do your dorsiflexion, plantarflexion of the first ray in the plane of the floor. So that getting that rotation right is important when you place this jig.
You can see fluoroscopy is used just to ensure appropriate placement of those guide pins, also getting a sesamoidal axial view, just to ensure that everything's exactly the way you want it. So, because as you start to correct, you want to make sure that those sesamoids are sitting up and under and exactly where you want them to be. The next step that you see Dr. Steinlaw doing is just kind of go ahead and correcting that paddle. This paddle you want to be superior on the dorsal aspect of the first metatarsal, but also slightly medial. And you can kind of see him checking it under fluoroscopy to see the appropriate position on where that first guide pin is going to sit. So as everything kind of clears up here in a second, you'll see that the guide pin will be sitting just superior and just proximal to the sesamoidal apparatus, as well as the articular flare right at the base of the metatarsal head. So any techniques or kind of pearls just to ensure?
Yeah, and so as you can see, I always verify the correct position of this using fluoro. Don't just fire in your wire and then have a less than ideal position for this. And then as you can see, you use the beaver blade. I use a hemostat, make sure I spread, you could have that distal branch of the SPN kind of in that location. And then from here, he's firing the M1 wire for the reduction clamp.
There's a bicortical fixation on this pin as well too. Go ahead and lock that pin in place, and this will allow for correction both the frontal and transverse plane. If you'd actually like more correction, you can actually go ahead and rotate the pin over, go ahead and lock that second distal screw, which Dr. Serrato is showing you, as you go ahead and compress things down. The nice thing with this handle, it's very ergonomic. What it does is it corrects first in your transverse plane for your 1-2 IM angle, as well as frontal plane rotation of those sesamoids up and under. And you can see a final fluoroscopic exam showing appropriate reduction of the IMA with appropriate position of the sesamoids.
He's got nice correction as well of the rotation of that first ray, accepting it's a cadaver, but you want to see the two sesamoids right underneath the metatarsal head. So I look for that, and if you need to change it, you can undo your your distal thumb screw, change the rotation of that wire, and get more correction, and then tighten it up again. Then you can then feel the other metatarsal heads and undo the distal nut and translate the first ray planter so that you've got the first ray correctly dorsiflexed and plantarflexed. So those two screws on the device on the first ray there will allow you to correct rotation and dorsiflexion, plantarflexion.
And one quick thing that we'll come back to later during this discussion is you can see a little bit of medial gapping. As you go ahead and get everything corrected and back around, you'll definitely see a little bit of gapping on this thing. So what we'll do next is we'll move into a young adapted surgeon testimonial. Dr. Meisner is going to kind of go over her testimonial on her first thoughts on PROstep.
Having performed MIS Lapidus since 2017, I am remarkably impressed by the new PROstep MIS jig's multifaceted ability to not only dramatically and reproducibly correct rotation, abduction, and valgus deformity, but to then compress and reduce first TMT. The jig and screw construct is a game changer.
So now the second video is going to highlight the actual joint preparation and then the compression. So as you can see, Dr. Steinlauf has made a small dorsal, about a 1 centimeter incision, just medial to the EHL, and he's placing what's called the joint finder into the first tarsometatarsal joint. And you can see the orientation for which that goes. This is a fairly flat but blunt device. It's very easy to get it into that joint. And I try to get this kind of just medial to the EHL, but center in the joint, and I kind of confirm that on my x-ray. From here, you can see the distractor and compressor device, and we've got the joint finder clamp on it. So it has multiple holes, as you can see, so you can accommodate different widths of different patients' feet. And what you want to do is you want to find the hole that allows you to place the jig as close to the skin as possible. So he's kind of showing all of the different holes, and basically he's going to just work his way to the point where he gets to one where he feels like he's at the right position against the skin. Now he's showing on the video, you need to be careful to make sure when you start pinning this that the jig isn't placed in too much external or internal rotation, because that can set off ultimately at the end placement of your 5 millimeter screw. So he's pinned proximally, and there are going to be 4 holes, 2 proximal, 2 distal. The 2 proximal ones are parallel, and I typically put a collared wire in at least one of the holes proximal, and then the hole distal to the joint closest to the joint. And so that allows, when you do a lot of this distraction, because you can get a fair amount of force with that, it'll help prevent your jig from getting pulled away. And so he's looking on x-ray and he's confirming, and I think what he's highlighting here is the correct position of this jig. You want to make sure that this distractor and compressor is placed at the dorsal half of your cuneiform first metatarsal line. And this is pretty important, because if you don't, then where your pins are placed, you're going to run into that problem later on when you're trying to pass the wire, drill, and place the 5 millimeter screw. So you need to make sure that you've put this up on the dorsal half, and it's critical to make sure that you have an accurate lateral view. And Alistair, if you want to talk about what he's doing in order to get that.
So your cues here are obviously palpation, and you want to see that jig to be perpendicular to the floor. So what Steve is doing here is he's using a flat plate on the bottom of the foot, so he's got the correct rotation, and then checking when he's got his lateral view here that the jig is overlying the top half of the medial cuneiform and the top half of the metatarsal shaft. So that means that he's got his position of his distractor correctly located on the medial border of the foot.
So once he feels like this has been in the correct position, he's going to place that 4th oblique pin in the first metatarsal. And so he inserted that little attachment that looks like a little arrow, and you want that arrow pointing to your joint. And then I just place it by hand, because this is going to come in an oblique angle. And you're going to take this bicortical across both the medial and the lateral cortices of the first metatarsal. Make sure this doesn't go into the second, because again, you're going to now try to distract this joint, and if that guide pin is in the second, you're going to have a hard time doing that.
So this wire also should be aiming for the base of the second metatarsal, because it's going to be your guide for the 1-2 screw when the time comes.
So you can see that in that you have your 3 parallel pins, but the most distal one is that more oblique one. So once he's got the distractor compressor secured, now he's going to go ahead and he's going to get some more distraction. So in a counterclockwise fashion, he's just turning this, allowing some more distraction at the joint. What he's showing here, and I think on the floor you'll see a little bit of gapping, and now at this point he's going to go in and just release some of the soft tissue, the capsule, both plantar, carefully over the medial side. He's showing he's using, in the beginning, a beaver blade, but I think surgeons have different techniques. I like to use that straight elevator in the PROstep MIS instrumentation kit, and it has just the perfect curve to be able to get down there and I feel like safely release the plantar capsule for myself. And then at that point, I'll try to go back again and get a little more distraction.
Yeah, use that. You get a good feel for the soft tissue when you're just penetrating out through all the margins of the joint. Obviously, be careful on that dorsal lateral side that you're not into the neurovascular bundle or damaging the EHL tendon.
So once he's done the joint release, you can see he's going back to trying to distract some more, again in a counterclockwise fashion, and you can even see the amount of threads that are being turned. And on the floor, you'll see it's pretty impressive what amount of distraction I've been able to accomplish with the cases that I've done with this. And so once it's distracted, surgeons will then introduce the arthrodesis burrs, which, as we've highlighted, there's multiple lengths and shapes to them. They work very well for different types of joints. To be able to come in here, it attaches to the cannula, irrigates, and allows you to safely remove the cartilage without removing the bone. And some surgeons, like you see with Dr. Steinloff, he put the scope in there for him to visualize the whole joint. And you can see how well it's removed large segments, and he's going back in there to finish removing the rest of the cartilage. Every surgeon, again, has different tools and tricks. For me, this incision with small Regnell retractors, I've actually been quite surprised how well I see through the whole joint. And so I don't think you guys should be nervous on the idea that you're not going to be able to be sure if you've done a good job preparing the joint. You can use a scope, or you could just use your eye even through the small incision. And then, again, all of us have different ways we prep it. I like to introduce that small elevator again, do any of fine, end removal of any residual cartilage. And then I'm going to prepare the subchondral surface. So Dr. Steinloff is showing he's using one of the arthrodesis burrs, and he's actually just making little punch holes into the subchondral plate. Other surgeons like to leave the subchondral bone completely intact in that sense. There's also in, Stryker has in their joint prep kit, you could use like the pointed awl to make. Whatever your choice is for joint preparation, you'll be able to accomplish it through this small incision.
So the irrigation there as well is important to point out. It's there to keep the joint cool so that you're not getting any heat issues, but also the irrigation will help to wash out all the cartilage debris, because we want all of that out, as little fragments of cartilage might interfere with the biology of bone healing, and we want to make sure that all those fragments of cartilage are removed.
So now Dr. Steinloff is compressing. So he's reintroduced the screwdriver, and now he's turning clockwise. And he's taking this down, and if you notice, he put the joint finder back in, and because he's allowing himself to be able to get to the point where the joint is starting to compress without over compression with it. And I think that's an important point with this. This is a really powerful tool to get some substantial compression. And as tempting as that might seem, if it over compresses, remember your compressing jig is on the medial side, and what that could do is start to gap open laterally, and you could potentially see a little loss in the correction of that IMA. So you want contact, but you don't need excessive compression.
Yeah, you might cause loss of reduction. So I get to the point where I approximate it on the lateral side, but I don't want to close it on the medial side, because that's important from the point of view of getting your correction. And your screw construct will hold that medial gap open. It'll buttress it as part of the sort of concept of that non-variable pitch screw. Thank you.
Stryker's 3-screw construct MIS Lapidus system has given me complete confidence in early weight bearing and an aggressive post-operative rehab protocol. The procedure, method, technique, and fixation eliminates any concerns about instability, incisional, and soft tissue complications, and has made me more confident in aggressive post-op recovery.
So back to our video here, prepared earlier with Dr. Steinloff. So he's now going to explain how we're going to get our screw fixation in. So he's already taken off the distal compressor distractor, and he's also placed his 1-2 screw here, which we can see on this X-ray here, that's going to help hold the first and second ray correctly reduced. He's trimming the wires on the compressor distractor when it's now closed, so that he can get the aiming jig on for the 5mm screw. So what we're going to do is identify where the end of that screw is going to sit. What we're aiming for is a plantar position on the medial cuneiform, so that the aiming device is targeted towards that. So we basically identify the starting point, which is on the dorsal side of the first metatarsal, just proximal to the MTP joint, and the distal end of that screw is going to end up on the plantar side of the medial cuneiform. So what he's doing here is on X-ray, he's identifying that medial area on the medial cuneiform on the plantar side, and then he's going to put his guide wire in perpendicular to the plantar side of the foot to allow the correct orientation of the targeting jig. You can also palpate the navicular and the medial cuneiform and make sure that you're putting this wire in the right position. So that will also be used with a thumb screw to correct the targeting of the screw and the wire on the AP plane. So now he's placed that wire and he's checked that it's in the correct position on the medial cuneiform and just inferior to his compressor distractor. This is the targeting guide for the screw, and we can see there's a little notch on there as well as a guide hole, and that little notch will allow us to put like a 2x12 burr in there to start as a pilot hole to get your wire in place. So now he's trying to get this distal end of the targeting device over the top of the first metatarsal head. So he's made a big enough incision so he can see the extensor hallucis longus, and then slide this in so that it's just alongside the extensor hallucis longus. And then he's going to fix that jig in place on the distal end. And now he can put a wire on it, and he can bring the proximal end in and out so that the wire correctly targets right down the middle of the first metatarsal as well as into the medial cuneiform. Ryan, how have you found this? Have you been able to target this accurately?
Yeah, so I think one of the key features on the jig is it's got the external alignment to make sure you're in appropriate AP. You want to make sure that the two lines are lined up over the top, and that's on the lateralmost aspect. We're actually scratching the medialmost aspect of the jig. You can see kind of the lines right here, and once you know that that's lined up, you're looking right down the gun sight of that, and that's what he's marking out there. But I definitely think taking your time and getting appropriate prep of that thing distally, like what Dr. Younger was saying, and really creating a little bit of a pilot hole really save you a lot of headache down the road and skiving that wire. So
it's a thicker anti-skive wire, but if you make the pilot hole, the problem with this is that if you lift the wire up enough to get easily into the bone, it's potentially going to be too steep an angle. And if you drop your hand far enough down with a distal starting point, you're going to potentially skive up the bone. So a little sort of starting hole, just where that notch is marked, is great to just help getting that anti-skive wire up and into the medial cuneiform. And you can see here that Dr. Steinloff is now checking and making sure he's got the right position. So you want to make sure that this is going down to the plantar side of the TMT joint and the plantar side of the medial cuneiform to act as essentially your fixation on the plantar side of the joint will give you a really nice rigid construct. He's making sure he's got this at the right length, and in this particular case he's measuring for a 75 screw. So these 5mm screws that go up in this position go up in 5mm increments. You want to make sure that it's going to get appropriate grab of the medial cuneiform, but not going into the to the navicular cuneiform joint. But equally, you want to make sure that the head of that screw is sitting on the cortex of the bone to give you the maximum amount of fixation in this 5mm screw. So he's checking that on the AP and lateral view. You want to make sure that it's absolutely up the middle of those bones, because if you're a little bit off to the side, you might be close to part of that screw being outside the bone. So once he's checked that, he's going to then make sure that his alignment is correct. Any tips here, Becky? Thoughts?
Well, one of the things that I harp on when I train surgeons and I train fellows on this is for the guide pin for the 5.0, when I'm looking at my AP view, if I can cheat the guide pin to be on the slightly medial in the first cuneiform, the medial cuneiform, because if you actually look at the anatomy of the cuneiform, it actually kind of tapers laterally. So you know you've got better bone if you're just slightly medial to the midline when I put that guide pin in.
So Dr. Signoff is now taking out off the jig, because we've now got the guide wire up the middle where we want it to be. And then he's going to carefully make sure that the extensor hallucis longus is out the way with this guide here that's chamfered to allow it to sit right down on the bone. And he's going to take the drill. So this drill has no lag component. It's the same size as the core of the screw, so that we're getting thread fixation all the way from the metatarsal distally all the way through the subchondral bone and up into the metaphyseal bone in the medial cuneiform. So this is him measuring his depth here. The distal end is correctly aligned, so it's not towards the undersurface of the navicular or towards the navicular cuneiform joint. In this trajectory, actually, it tends to pass underneath the navicular. So he's taking the cannulated drill. I like to drill, obviously, the distal cortex, and then I go across the two subchondral plates, so the subchondral plate each side of the first TMT joint. But I don't worry about going up into the metaphyseal bone so that it keeps your guide wire in there, and the screw will cut that. But I do want the subchondral bone to be drilled so that it doesn't fracture as we put the screw across it. So he's then going to take the 5mm screw, and as we see him insert it, you can see obviously it's full thread. The pitch is constant throughout the length of this screw, and the pitch is also consistent through the head of this screw, so that we're specifically not wanting any compression. If you use, for example, a partial thread screw in this environment, you're going to miss all the opportunity of transfixing that subchondral bone, where the strength of the fixation, or much of the strength of the fixation, is going to lie. So he's going to make sure that the screw comes down. There's a little mark on the screwdriver here to make sure that you're vertically oriented. In this particular case, Steve is going to look at the screw head and make sure that it's appropriately down and into the edge of the bone. So these three screws will all end up being essentially within the bone itself. There'll be no metal sitting outside the cortex of the bone once we're done. And this will come down and sit flush. So you don't want to over-insert it too, because you're going to lose potential of some of that caudal fixation. Any thoughts, Ryan?
No, I think it's critical and key to really kind of look for that laser line as that screw's going in, and make sure that when you go to seat the screwdriver shaft into the actual head, that the chamfer, you know where the chamfer is. Because sometimes you don't have an incision that's open that much, and I think that's the key when people first start, is they like to keep with much smaller incisions and try and run on that. So I definitely think that a little pearl is knowing where that laser line is on the screwdriver and where it pertains to the head of the screw, so you can really minimize the amount of fluoro that's needed.
So this is the final view here of Dr. Steinoff's dissection. You see this wire here is the trajectory for the third screw. He's aiming to start obviously in the base of the first metatarsal, and it's good to aim this down so it catches the medial cuneiform and ends up in the intermediate cuneiform proximal to the second TMT joint. And that'll give you rigid immobilization and rotation in addition to this screw at the first TMT joint. So the final construct is this screw, obviously 1, 2, holding the IM angle reduced, as we can see here, second screw coming across here. And this screw on this view looks like it's into the navicular, but if you get a lateral view or you lift the foot up, you'll find that this is just at the just within the medial cuneiform. So again, good to check on your lateral view and look at that, because that plantar position will make it look like this on the AP view.
So moving right along with the show, we were going to try and get a hold of Dr. Fong Lei. We were able to connect with him earlier and do have a prior recorded Q&A session with him. He's based out of Sacramento, California. So we have a little bit of a teleconference with Dr. Fong Lei from Sacramento, California, and he's going to kind of go over some of his early experiences with the PROstep MIS Lapidus system for us.
Sure, guys. Thanks for having me.
So if you want to kind of go over what was the first thing that you really noticed with the system, what made you jump to the PROstep Lapidus procedure?
Yeah, so for me, I think it's a game changer in a sense. I know that PROstep for the bunion correction has been around for quite some time, but nothing really out in the market for minimal invasive for Lapidus arthrodesis. And I think for me, I've always been hesitant for patients who have a very hypermobile first ray to kind of go with the PROstep system, just because I was always afraid of recurrence. So when this came out, I hopped right on, because I think it's a game changer for those patients that we all treat with hypermobility. And I think it allows for them to have smaller scars and earlier weight bearing.
Do you have any thoughts about how much intermetatarsal angle would make you go for a PROstep Lapidus versus a distal chevron?
I think a distal chevron, with my experience, you always want to start, when you're first starting these, you want to start with a larger IM angle. The ones with very minimum IM angles, I think they're very hard for that trajectory, for that first screw that you place. So for me, I think it's not really the angle, it's more the hypermobility. If a patient has a large IM angle, but they're pretty stable and there's no hypermobility or very little, then I think I go with the chevron, the distal chevron. But if it's a more large IM angle, say like a 18 to 24 or something that's severely hypermobile, or maybe with DJD, I definitely go for the MIS Lapidus.
So what percentage of your practice do you think is going to be a distal chevron versus a percutaneous Lapidus?
Well, most of the cases I see in my practice, I'd say probably like 30% are probably distal chevron, and the other 70 are probably MIS Lapidus. And for me, always doing the traditional Lapifuse system, I think this is huge to go to minimally invasive for that type of technique.
Dr. Lei, this is Rebecca Serrato. Thank you very much for joining us. Question, could you give some pearls or hints to those thinking about doing it? What would be ways that they could, what are a couple of simple pearls you would give them when they're about to start their first case?
Yeah, I mean, number one, you definitely have to get into a lab. You have to try this, get your hands on it before you do it on a patient. That's definitely number one. I think number two is trying to learn how to position that lateral, the medial jig. So you have that jig that allows you to distract and also compress the joint. If that jig is too medial, too plantar, you're gonna struggle quite a bit. And I feel like at that point, you'd have to cut the pins and make it work. It's a big headache. So if you get that in the right position, check it on your lateral view, your AP views, make sure in your right position. I think that's gonna be a game changer. And I think the last tip for me, because initially I struggled, looking at the guide and everything, the guide shows you should go pretty far distal with your screw going from distal first to the medial cuneiform. And I felt like you're going over that little hump over the first ray, and we all have a dorsal eminence there with these deformities that when you're going over that, it keeps skiving. So I feel like if you go mid shaft, I think you have a better way of kind of making that screw in the right position.
Thank you.
Great.
Oh, you're welcome. Thank you.
So you've been using the PROstep platform for some time across the board, just using the burrs and everything. How do you think that the PROstep MIS Lapidus really kind of rounds out your experience with the burrs, the systems, the screws?
Well, I think it's huge. I love MAS. I think that's huge. You know, I'm pretty sure all you guys use it as well. I mean, like I heard you guys talking earlier about Charcot. I think it's a game changer for Charcot in addition to all these other deformities that we treat. Um, for me, I think the adding the irrigation system too, I think is huge. It allows for the bone to not overheat, especially when you can see the joint, you can exactly irrigate all that debris that you're getting out of the first TMTJ. I think that's huge. So being able to get that all out, irrigate it out, I think that's very important because you don't want to leave some of that debris in there if it's just cartilage. I don't think that's going to lead to a adequate fusion. So I think that's huge addition to what I've been doing in the past.
Since you've made the jump from LapiFuse over to PROstep Lapidus, have you noticed any change in your postoperative recovery? Have you noticed any change in the overall appearance of the foot and ankle following those types of surgeries? And if so, can you explain on them?
Sure, yeah. So I think the huge thing is just reduction of swelling. I think that's huge. You're allowing these tiny little incisions compared to the bigger incisions we were doing for LapiFuse. So reduction of swelling is huge. And I'm a big proponent of too much swelling is going to cause delayed healing in my patient population. So I think that allows them to heal faster, especially the wounds, and it allows you to treat patients with multiple comorbidities. In addition to that, I feel like they're walking a little bit sooner. You know, they're walking in their boots a lot sooner than I would have in the past with LapiFuse. I'm more traditional. I usually do a posterior splint for 2 weeks. Then it's depending on the patient. Majority of the time, LapiFuse, even though it's a strong construct, I still might cast my patients. And when you do that, you lose some range of motion, you get some calf atrophy, things like that. These patients, they're walking right away, just like the PROstep Chevron system. So I think it's a game changer for these patients. Even though it's midfoot, they can definitely walk on it sooner.
How are you finding the range of motion in the first MTP joint comparing against the LapiFuse?
So I've always done the lateral release, even if I'm doing a LapiFuse, if I'm doing a Chevron. I still like the lateral release because I feel like it brings the hallux over. And in addition to that, if you're doing an Aiken, it definitely makes the toe straight. So the range of motion, it really depends. I think if you have a long first ray, you're going to always have limited range of motion. This system, it doesn't allow for a lot of shortening, I think, which is huge compared to other systems out there. So I feel like you preserve that metatarsal parabola and it allows for the range of motion to come back. But it does take extensive physical therapy before they kind of get back. But I feel like it's going to help them down the long run.
Great, thank you. Thank you for taking time out of the day. We know you're very busy today, so we really appreciate your time. Thank you.
Oh, thank you, guys. Thank you, Dr. Scott, Dr. Serrato, Dr. Younger. Thank you for your time, guys.
A pleasure. Thank you.
So as we heard in Dr. Lay's testimonial, there is definitely a recommendation to get out there and get educated and practice these in a lab before, committing to doing this on your patients. And Stryker is committed to the education of its surgeons. And highlighted here are some of the regional courses and training opportunities that are going to be throughout the country in 2024, as you can see here. But there's other training opportunities, not only the 6 regional courses, but there's peak visits, MIS labs that they offer at a lot of the society meetings. RV and teach trucks are going to be available. Speak to clinical sale managers in your area. See if they could coordinate a lab or even a local surgeon that could help you with this as well. And also Stryker has virtual reality. They can oftentimes set you up with the virtual reality goggles, and you can actually go through this procedure several times before you even go to a regional cadaveric course. And so when we talk about the surgeon learning journey, not just with MIS Lapidus, but just MIS in general, when we talk about the sort of in-office like MIS introduction, typically that begins with sawbones. And sawbones is uniquely helpful in the MIS world because, again, you're not seeing the burr, you're not necessarily seeing some of the tools as you're doing this. So it's really helpful in the beginning with a sawbone. First, just visualize what you're about to do. I mentioned virtual reality. And then at that point, I think it's ready for you to enroll in some of these MIS training opportunities. And when we talk about pre-work, that's oftentimes online. And so you guys have an opportunity, and Stryker has great information. It can teach you about sort of the evolution and history of MIS, equipment, room setup. So all of that stuff is pretty clear for you when you come and learn about specific techniques, including, as mentioned here, the MIS chylectomy, hammer toes, metatarsalgia, calc osteotomies, and bunionettes. You can also be introduced online to the MIS hallux valgus correction, whether it's through the Lapidus or even the Mica. And then at that point, it's in person, and these are the regional courses. And so you can learn all of these techniques in these different regional courses, both the freehand Mica as well as use of the solo guide, joint fusion preparation, the Lapidus introduction and technique, the Mica cadaveric lab, and the labs for the Lapidus and the joint preparation. And I think this is really important, and Stryker does a really great job giving you all of the resources to be well prepared on all of these techniques when you start adding this to your practice.
Great. So we're going to kind of move into that Q&A session. So like I had said earlier, if you guys have questions or concerns, maybe stuff that we had discussed or something that we brought up that you guys would like to pose to the audience, please submit those. I'll start with the first one while we wait and see if we've received any questions. Looking at metaductus, we kind of hinted at it earlier. Do you think metaductus changes your approach with PROstep MIS Lapidus? And if a patient has a very large amount of metaductus, do you think that they're an appropriate candidate for PROstep Lapidus?
Yeah, I've been through quite a journey since starting doing a percutaneous Lapidus to work out how we deal with metatarsus adductus. And the very first thing is to recognize it, because you can be lulled into a false sense of security that you can get away with a distal chevron, when in fact, if you look at where the metatarsals lie in relation to the midfoot, which is really what's relevant for a hallux valgus deformity, that you're going to get your correction bumping into the second metatarsal head, and it's going to get in the way of your correction. So I've tried distal osteotomies, and they do work, and there's a fair amount of discussion. You can do that percutaneous. But as you move them laterally, they're going to also go into valgus, and so you're going to get valgus drift of your lesser toes. So I wanted to get a technique by which I could get the proximal correction. So what I've used is a 2x12 burr and done oblique proximal osteotomies, and then I will shuck the foot and make sure that I can move it into varus and then back into valgus. That'll allow me to get the lesser metatarsal heads out of the way with proximal percutaneous osteotomy. So you can do metatarsus adductus all percutaneous with a first TMT fusion with a PROstep Lapidus. So to me, that's become something, and it's really the third thing in looking at your hallux valgus correction. You got obviously minor deformities with a distal chevron Aiken, the hypermobile first ray, or major deformities with the percutaneous Lapidus, and then obviously correction of metatarsus adductus. But the percutaneous Lapidus gives you nice stability. So if you do those osteotomies, you've got the first ray stabilized. And I was fixating those initially, and now I just use the 1-2 screw and just extend it more laterally in the foot, and it allows me to hold those lesser osteotomies over. You agree?
Yeah, I mean, I echo Alistair's comments on this. I think, first of all, I've learned that I need to be more aggressive with metatarsus adductus, but I also feel comfortable doing a Lapidus. In fact, like I had mentioned, there are articles that suggest potentially the risk of recurrence may be decreased in patients with metatarsus adductus with the use of a Lapidus. But I have also done proximal closing wedge osteotomies, corrected the adductus, and did very well with a distal Mica procedure as well. But I think the important thing is we can't ignore it, and particularly if you see the lesser toes in a sublux position, that is a deformity that has to be corrected with your bunion.
Great, great. We did receive a question from the audience. The question is prep or no prep for the intercuneiform joints or first met C2 joint? What are your takes on multi-fusion right there at the intercuneiform, kind of a keystone fusion type?
Yeah, I did do that initially. I don't do it anymore. I put my 2x12 burr down the lateral side of the first ray. I've not done that more recently, and I don't think it's changed the correction. I get a bit worried about the dissection at that area. Becky?
What I will try to do, I try to sometimes get a spot weld. So through that small incision using the straight elevator, I'll go around M1 and remove some of the cartilage between M1 and the proximal medial corner of M2 and sort of debride that area. And even I'll take that kind of pointed awl and just make a couple of little preparations in that with my idea that I may get some spot welding in that.
Great. Awesome. One of the concerns we hear all the time are you concerned for the M1 to M2 screw, over stiffening the construct, breaking with range of motion? What are your thoughts? What are your takes on that M1 to M2 screw?
Yeah, I've used an M1, M2 screw right since I started doing the percutaneous lapidus in 2017, and I've seen few complications with it. I used it initially to get that final closure of the intermetatarsal angle and make sure that I got everything sort of stable by using that 1-2 screw. But it also helps to control the rotation of the first ray. So, and it's important though to target it correctly. So long as you're taking that screw and the angles designed on that jig to bring it into the metaphyseal bone on the proximal end of the second metatarsal, and that's important to make sure you get into that zone. So I think it's an important part of the construct, and I'd encourage everyone to use it, both for just getting that final closure of the IM angle, but also to maintain the stability of the construct.
I agree, but I think the key is, as he had mentioned, you want to make sure that the distal end of that screw is aiming into the proximal metaphyseal portion. I think when you see complications from it, it tends to be targeted fairly distal in the second metatarsal, and that's all diaphyseal. And that's where I think surgeons can run into some complications with that.
Great. So we kind of hinted at it earlier as well too, are you concerned about that medial gapping during compression when you're go ahead and driving that in? And if you are concerned, are you bone grafting, or is there anything you're doing that you've changed along the way to lessen the stress after leaving a case with a medial gap?
I've seen some pretty big gaps over the years of doing the percutaneous lapidus, and so long as you keep that subchondral bone and you've got the fixation close to the joint line, you can imagine if you put a compression screw across there, you've got a huge long length of the shaft with no fixation going into a screw at one end and a head at the other, and you do need that compression to get stability. But if you put that 5mm screw in and you've got a bit of a gap medially, it's getting fixation. Because we're not over drilling either side of the joint, what we've got is rigid screw fixation in good bone, just right at the joint line, proximally and distally. So it actually acts to maintain the correction because it's going to open the medial side of the joint, but also as it does that, it's going to maintain stability. Now, I haven't used bone graft in my cases or very rarely used it. The fusion rate has been really high. I've identified one non-union out of the 300 I've done. So I think that even leaving a gap on the medial side is not an issue. I think that we're getting high fusion rates regardless. And again, it's understanding this concept or change, that's so different thought and approach to the fixation.
Great.
I mean, I would comment, I think in those patients where you've corrected a very wide 1-2 IMA and you get a pretty good size gap, I don't usually go back and graft if I see a little bit of spacing, which you often will when you do any kind of reduction with this. But those patients that have like a 22-degree IMA, when you close it down, that can be a pretty big gap. And so I will typically grab graft from usually the patient's calcaneus and just use that as a source.
Perfect. Okay, just to keep mindful of time, and one last question, and then we'll wrap things up. How often are you guys performing an Aiken in conjunction with your PROstep Lapidus or some sort of distal MP joint work?
I'll do an Aiken maybe 20-30% of the time. It just gives that little extra push to the correction. Patients tend to be happy with it, so I'll do my PROstep Lapidus, and I'll look at it, and if I feel like it just needs a little extra, I'll do an Aiken at the same time.
I have the same indications for it, but I would definitely say mine are more common. I probably say 75% of the time I'm doing an Aiken with it.
Great, great. Well, that kind of wraps up our session. Hopefully this was as entertaining for you guys as it was for us. We had a great time kind of going through all this. If you have questions or concerns that we didn't address, please reach out to your local representation or the management team from Stryker. They'll gladly go over all this stuff. I think the biggest takeaway from all of us is practice, practice, practice. This is definitely a real art, and the more you get your hands on it, the better it will be. But thank you very much for your time. Hope you all have a wonderful night. Good night.